Welcome to our video on adenomyosis and endometriosis. Let's get started. Here's our overview slide. Let's begin with adenomyosis. With regards to this topic, we'll be discussing the definition, pathophysiology, clinical features, diagnosis, and management. So let's begin with the definition. Adenomyosis is a benign condition where endometrial tissue grows into the myometrium. It's mostly found in multiparous women above the age of 40. The exact cause is unknown, although it's often found to coexist with endometriosis and leiomyomas. The endometrial tissue in the myometrium is hormone sensitive, and the tissue grows with every cycle, which leads to the characteristic enlarged, boggy uterus we see in adenomyosis. Patients can be asymptomatic. New-onset dysmenorrhea or painful menstruation and menorrhagia or heavy and prolonged menstrual bleeding are the most common symptoms. Patients with adenomyosis can also experience abnormal uterine bleeding and chronic pelvic pain. The diagnosis is mainly clinical with characteristic imaging findings supportive of the diagnosis. Pelvic physical exam characteristically reveals a symmetrically enlarged, boggy, mobile, soft, and tender uterus. Imaging such as ultrasound or MRI can be used. Even though MRI is more accurate, it's also more expensive and therefore not often used. A biopsy can be done to confirm the diagnosis, as well as rule out other causes of abnormal uterine bleeding, such as endometrial carcinoma. Here is an image of a pelvic MRI of a woman with adenomyosis affecting the posterior uterine wall. Note the gross enlargement of the posterior wall with multiple areas of hyperintensity that represent cystic spaces. On the anterior uterine wall, we can see a hypointense lesion, which represents a leiomyoma. Here is a gross hysterectomy specimen from a woman with adenomyosis. The top part represents the endometrial surface, and the serosa is at the bottom. Here we can see the soft adenomyotic areas compared to the more firm myometrial tissue. All right, let's try a question. A 35-year-old woman presents to the physician due to very painful menstruation. She says the pain is so severe that she has to miss work during those days. Pelvic ultrasound reveals a symmetrically enlarged globular uterus. What is the likely underlying mechanism of this patient's condition? All right, this patient with very painful menstruation and a symmetrically enlarged globular uterus on ultrasound most likely has adenomyosis. And as we just learned, this is a condition where endometrial tissue grows into the myometrium. Okay, moving on to management. Mildly symptomatic patients may be managed with NSAIDs alone for pain relief. Other pharmacological treatments include hormonal treatments such as combined oral contraceptive pills, IUDs, GnRH agonists, and progestins, such as levonorgestrel. Hormonal treatment aims to suppress menstruation, thereby improving symptoms. Interventional treatment with endometrial ablation or uterine artery embolization can be done in patients who no longer wish to conceive. Finally, surgical treatment with a hysterectomy is the definitive treatment for severely symptomatic patients, patients with recurrent disease, or patients who do not wish to conceive. Okay, let's move on to the last topic, endometriosis. Here is the sequence in which we'll be discussing endometriosis, beginning with the definition. Endometriosis is a condition where endometrial tissue is present outside of the uterus. The exact pathophysiology is not clearly understood, although the theory of retrograde menstruation has been proposed. This theory refers to the idea that endometriosis occurs as a result of retrograde menstruation, resulting in extrauterine endometrial tissue implantation. This extrauterine endometrial tissue reacts to hormones and undergoes similar changes to those of normal uterine tissue during the menstrual cycle. Here is an image which demonstrates endometriosis. Endometrial tissue can be implanted anywhere in the pelvic organs, peritoneum, and even extrapelvic organs. Common locations include the uterosacral ligament, rectovaginal septum, and posterior cul-de-sac, which can also be palpated as nodules on pelvic physical examination. Patients with endometriosis can be asymptomatic. Cyclical and chronic pelvic pain that worsens before menses and decreases or subsides with menses is a highly characteristic symptom. Dysmenorrhea, or painful but not heavy menstrual bleeding, is also characteristic and differentiates it from other disorders that cause both dysmenorrhea and heavy menstruation. Women may also experience dyspareunia, which refers to painful sexual intercourse, as well as infertility or decreased fertility. Infertility is believed to be linked to adhesions and pelvic architecture distortion. Finally, patients may experience dyschezia, which refers to painful defecation and rectal pain if the endometrial tissue is located at or near the rectum. The diagnosis begins with a history and pelvic physical exam. Physical exam will reveal a non-enlarged, non-tender, and immobile uterus. Patients also experience cervical motion tenderness as well as rectovaginal tenderness. An adnexal mass can also be detected and is commonly referred to as a chocolate cyst due to its gross appearance. Here's an image which is a gross image of a chocolate cyst. This appearance is a result of the cyst being filled with coagulated blood from endometriosis. Transvaginal ultrasound is usually the best initial step, which will reveal a normal-sized uterus, an ovarian endometrial cyst, and nodules on the bladder, rectovaginal septum, and cul-de-sac, among other locations. Here's another image, which is a transvaginal ultrasound of an ovarian endometrial cyst, or an endometrioma. It usually appears as unilocular, homogeneous, and hyperechoic. Laparoscopy is the confirmatory test, and endometriosis lesions will appear as blue-black lesions and may also be described to have a gunpowder appearance. Laparoscopy is also done when ultrasound findings are inconclusive. Here is a laparoscopic image of endometrial foci in the Douglas space and on the right sacrouterine ligament. Note the blue-black appearance of these lesions. Okay, moving on to management. Endometriosis is a chronic disease that can require long-term management. Medical therapy aims to relieve the symptoms by suppressing endometrial tissue, but its effects are temporary. NSAIDs can be used for pain management. Combined oral contraceptive pills suppress ovulation, leading to endometrial tissue atrophy. GnRH agonists can be used for severe symptoms and work on decreasing the release of LH and FSH and the subsequent decrease of estrogen levels. Aromatase inhibitors can be used to decrease estrogen levels by inhibiting the conversion of androgens to estrogens. Surgical resection can be either conservative or definitive. Conservative surgical resection with laparoscopic excision and ablation of endometrial tissue is usually the first line. Definitive surgical resection with hysterectomy, with or without oophorectomy, is reserved for patients with severe refractory symptoms and for women who no longer wish to conceive. Hysterectomy is considered a second-line surgical treatment after laparoscopic resection. All right, let's try a question. A 31-year-old woman presents to the physician due to cyclical pelvic pain that worsens before the onset of her period. Her menses occur at a regular 28-day interval and have moderate to light flow. Over-the-counter analgesics have not helped. She also complains of painful sexual intercourse and occasionally has pain during defecation. On physical examination, the uterus is normal-sized and non-tender, and no adnexal masses are palpated. What is the next step in managing the symptoms of this patient? All right, this patient is presenting with cyclical pelvic pain that worsens before the onset of her period, painful sexual intercourse, and pain during defecation, so she most likely has endometriosis. Remember that menstruation in endometriosis is painful but not heavy. Physical examination in patients with endometriosis usually reveals a normal-sized and non-tender uterus. This patient has tried over-the-counter analgesics, but they have not helped. This makes the best next step in management combined oral contraceptives. Combined oral contraceptives will help decrease the severity of pain and the size of endometriotic lesions. Okay, let's wrap up with one more point about the management. Ultimately, when deciding on medical versus surgical treatment, you need to consider factors such as the patient's desire to conceive, as well as if there are any contraindications to medical therapy. Here is a table that summarizes the key features of the conditions we've just discussed. These are all high yield for the boards, so make sure to take some time to understand them and learn them well. Okay, let's wrap up with a final question. A 32-year-old woman comes to the physician due to pelvic pain that starts a couple of days before her menses and gets better after she starts menstruating. Over-the-counter painkillers have not relieved her symptoms. She also complains of pain during sexual intercourse. Menses occur at a regular 30-day interval and last for 5 days. She is currently sexually active and uses combined oral contraceptives. Physical exam reveals clear vaginal discharge and rectovaginal tenderness. The remaining portion of the workup, including a transvaginal ultrasound, is normal. What is the best next step in management? A. Laser ablation. B. Hysteroscopy. C. CT scan of the pelvis. Or D. Laparoscopy. All right, so this patient is presenting with characteristic pain of endometriosis, where her pain starts a couple of days before her menses and gets better after she starts menstruating. Pain during sexual intercourse and rectovaginal tenderness on physical exam are also characteristic findings of endometriosis. Since painkillers have not helped and using combined oral contraceptives has not resolved their symptoms and the ultrasound was inconclusive, the next best step in management is laparoscopy to confirm the diagnosis. So the correct answer is option D. Laparoscopy will also allow laser ablation or excision of the endometriotic lesions once the diagnosis has been confirmed. Recall from this slide that laparoscopy is the confirmatory test for endometriosis. It's used in case of inconclusive ultrasound findings in patients who continue to experience symptoms after the use of combined contraceptives. Option A is incorrect because before the initiation of any invasive treatments such as laser ablation, the diagnosis of endometriosis should first be confirmed given the normal ultrasound findings. Option B is incorrect because hysteroscopy is used in the diagnosis of uterine fibroids and not endometriosis. Patients with fibroids do not usually present with rectovaginal tenderness. Option C is incorrect because a CT scan of the pelvis is not recommended for diagnosing endometriosis due to nonspecific findings. So again, the correct answer is option D, laparoscopy. And that concludes this section.